All right, welcome back, all of you. Looks like there's a couple of them joining in here yet, so I'll just kind of wait maybe a minute here till we get started. Did you guys, were you guys able to print off your practical sheet so you guys can kind of follow on through? Good, okay. And then also, you know what I also suggest is if you could have handy, how does it looks very different. Well, I think it's probably just maybe in a different font, and I only have three in the protocol to set up, but what I do have is maybe a little bit more of identifying, going to the viewing and identifying, you know, the rotator cuff tendons off of the coronals and off of the sagittals. So, you know, it shouldn't look a whole lot different. Just maybe just bigger font, I think. But I do think it's a good idea to go ahead and have your book with you also. That as we talk about things, we can kind of refer to what our book is saying, because I think that'll help as well. Okay. Looks like one is still reconnecting here. I'm hoping you guys like the MRI of the shoulder. I like scanning shoulders. Pages in the book, pages 149 is what we'll start with, and that's the axial. You're welcome. So I already went under the upper extremity here. And then as you open that, you'll notice that there is a right shoulder that is in here. So I just pulled that protocol over. So right off the bat, we're going to do a survey, correct? And what we'll need to do is make sure that we have the correct coil. The coil that we are going to utilize is going to be a flex, and we're going to use the flex, I think it's a flex M. Oh, thank you. It is recording as far as, I'll record it on mine, but it's also being recorded for Sue Ellen, that I think just what she did last semester. So there should be a flex coil in here. The Sense Flex M is the coil that we're going to utilize. And we're going to run a 3-plane. We're going to scan that. And here is my 3-plane pilot. Now notice right off the bat by looking at this 3-plane, I should see that this is a right shoulder that we are scanning. We can go ahead and position our calibration lines and just run that. And then the very first series that we are going to set up is a proton density axial spare, which is also a fat sat, right? So as I open that up, and if I want to go ahead and kind of take my lines off here, I can kind of straighten them up here for now. I can take off my volume box. But as I page through my coronals, you know, I really want the nice corona where I can see my humeral head, which is there. And in my axials, I can page through my axials and kind of get the nice through the humeral head as well. And on my sagittals, I really like to get a sagittal where I can see my humeral head and more of the shaft, okay? And the reason is because I like to do my axial slices to be perpendicular with the shaft. So if your lines are straight here, I really want to angle them to be perpendicular. And then I also want to make sure that my axials, if I bring my center slice right through where this is your supraspinatus muscle, and then it goes underneath the AC joint and your tendon would lie here, I kind of want to get a slice going straight through that. And notice that there's hardly any angle on these axials. But again, it depends on if that patient is in there in a neutral position with their shoulder, or are they in pain, and is their arm kind of, or their shoulder kind of like, shrugged forward or not. That might be, dependent then, do you need to angle for these axials one way or the other? I can see here is my AC joint here, okay? So really this bone is part of the acromion bone, okay? So I want to go above that, and I want to go all the way down. Now our book talks about going through the surgical neck of the humeral head. So here is my humeral head. This little part is what they call the anatomical neck, but down here is where they would call the surgical neck. So we want to make sure we go all the way through that. And then if I look here, here's my glenoid. I know I have my labrums right here, and I want to make sure I get all the way through that in case there's something going on in this inferior aspect here, okay? My appropriate field of view that I use, so here's my field of view box over my axial plane here, and I can kind of straighten this up a little bit, okay? So I have a field of view of 150 by 150, and that, if I kind of page through a couple of my axials, that actually is pretty good. I don't really think I can go any like to 112 because I'm going to start to cut some things off, especially as we're slicing through, right? So a 150, a 160, that's probably going to be a pretty average that you're going to want to use. And now if I go to my geometry for my voxel size, remember that our book talked about utilizing voxels of 0.8 or less. So I'm going to go to 0.8 so I get good resolution on these images. Okay. My slice thickness, my gap, my rest slab, if I look at my book, they utilize slice thickness of 3 with like a 0.5 gap. So let's just put that in. It's 3 at a 0.5 gap, okay? If I turn my slices back on, and if I notice that my coverage looks pretty good, I am above the AC joint. I am all the way down through my surgical neck, actually into more of that diaphysis of the humerus, right? And I can move this into the center here. Okay. Whoops, whoa. Straighten that back up. Gonna bring that down in the center there. Notice I do have a rest slab on here, and we can let this rest slab on. If I look at the direction of my fold over down here, my fold over, I can go, here is my axial, I can go head to foot or right to left. Well, I'm going to go head to foot. So some of you might be thinking then, well, why do I need a rest slab if my motion's going to go A to P here, and here is my chest cavity? But if you think about it, you do have, and if we have the neck out here, and then we have your subclavian artery that comes across, we have blood flow coming across. So this rest slab will kind of help minimize some of the flow motion from our arteries and veins by putting it over here. So hopefully that makes sense for you. Over here on this axial, this is really where your subclavian artery and veins going to be. So we can minimize some of this blood flow that's going to come across into that shoulder and hopefully get us a little bit prettier picture there. So my setup actually here looks pretty good. Okay, my rest slab, even though I have it in this area, I'm really looking at these structures. So, if you feel more comfortable moving it out, that's okay. You can go in a little bit, and I'm still going to get the coverage that I want. My contrast, this is a PD, so I have a 2400 TR and a 30 TE. And it's really odd. It looks like user defined here, and it's on user defined for TR. So let me just go ahead and change it to a range and say, you know, the lowest TR that I would want would be 2000. And then the highest TR I want, maybe let's go to 8000. What you'll notice then is it says that the actual TR is 4,713 milliseconds, and I can get that in one package. And it actually helped drop my time down, because with my user defined of 2400, it was making me do it in 3 packages. Okay, so that kind of helps me out, because I'm not real sure what exactly TR that I need for 27 slices, but I know I want this range, and the computer then tells me what TR to use. The TE is a 30, and that's really what I want. I want a high TR and I want a low TE to go ahead and get a proton density weighted image. My turbo factor is 7, and that's a good turbo factor. Otherwise, you know, sometimes if you feel like you need to move it up to 9, that's okay too, but we're in that range, right, of that, you know, 7, 9, maybe 10 type of a turbo factor for a PD weighted scan. Okay? What is nice, and I don't know if many of you look over here, but this does give you some nice tips to utilize when you're setting up scanning. And not all vendors have it, but I know Philips does, and I think the Siemens does as well. But it even gives you a tip of a TE of 25 to 30, and maybe a TR of 4800 to 5500 will get us good contrast between articular cartilage and synovial fluid. So that's kind of a nice tip to look at here. Okay? So now I got my time down to 3.5 minutes. Well, let me see what kind of necks I have. And I have a 2-neck scan, and that looks good. And if I go back, I didn't even turn on sense. So I don't even need to turn on sense, because my time is relatively short anyway. If you felt like your time was too long and you have a sense coil, you can turn on sense to bring that time down. Okay, so those are just some things that you can kind of start to play with. My SAR, I'm in normal SAR here. And I have to think, that's right, this is a fat sat. So I'm going to turn my volume box back on, and I'm going to position my slab appropriately. And I want to minimize as much air as I can. So that is how I would set up for my shim box. I can turn my slices back on, and notice that I'm just kind of cutting out some of this air around the shoulder joint. So, is fat sat suppression needed? Yes. I positioned my fat sat box. We already talked about phase. My phase is going A to P. So if you feel like you need fold over, you're going to need it turned on. What do you guys think? Do you guys think you need fold over going A to P or not? Anybody want to chime in? No. Okay. And if you look at this particular image, and if we even page through a couple, I would agree with you, Shalika, that you probably don't need it. But let's look over here. And the only reason that I can about guess that this is a female is because of the size of the shoulder joint here. It kind of looks more of a female body. And if I look here, this looks like part of the breast in the sagittal images here. So notice that as I go out into the more, on these sagittal images, as I go probably more medially, I'm getting more more breast tissue. So there is a little bit of anatomy that could wrap into your shoulder joint off of this breast tissue there. So I think I would want to keep it turned on. Now, if you had a patient and you absolutely seen there was nothing A to P on these, then you could possibly turn it off. But what I want you to understand or to try to think about is, even on this particular, because you don't see any anatomy, as we are slicing down, we are going to get in these lower areas more into breast tissue, so you could have some wrap occurring. So we're going to leave this fold over turned on for this particular scan. I positioned my slices. I like how they look. I like the weighting that I'm going to get. And I'm going to proceed and start. And that'll run for 3.5 minutes. The second thing I'm going to set up for is a PD coronal fat set. So I'm going to go ahead and start to set that up. Okay? And notice I got rest slabs down here. And if you want to take them out of the way here so you can kind of see your slices, you can. If you get confused, because, you know, it looks like my field of view box here is kind of warped, just straighten up your lines and you're going to get more of a straighter box to look at. They just get warped when you're putting these double angles on. So you can kind of try to straighten that box up if you want, or, you know, once you start positioning, you're going to be able to see, you know, a little bit better field of view box. But the first thing that we want to do is select our field of view that we want to utilize. And if I go to the geometry again, this has a 160 by 160. And if I turn my lines off so I can kind of see a little bit better. Coronal wise, that actually doesn't look too bad. I can get a really nice picture with a 160 millimeter field of view. Okay? Again, I have my supraspinatus muscle. Here's my tendon. I'm well below where the diaphysis are, well below the surgical neck here. Okay, so I like my field of view. I'm going to go ahead and for coronals, our book talks about a 0.3 thickness, or I'm sorry, a 3 millimeter thickness by a user defined, so that would really be a 0.3 gap, right? I don't want to say user defined, default. Default is the 0.3, okay? Now, before I start setting up my slices here, I need a better axial image. So I'm going to go ahead and drop in my axial that I just took, and I'm going to page through here. And notice that as I'm looking at these first sets of pictures here, I notice that these are down in this slice. So I'm going to need to go up, starting to get into the joint itself here, okay? And that looks about like a slice going right through the center of my humeral head. But I don't know what angle I need to pick, so I need to keep going until I see the supraspinatus muscle. And if I go all the way to the top, I'm in the skin there now. So now let me go down. This is the clavicle. I'm starting to see a little bit of the acromion. And right here is my AC joint. Here's my clavicle. This bigger bone that comes up is your acromion. And I know that because it's going to slice right through here, I know that my supraspinatus is right underneath that. So right here is an image of this muscle, which is your supraspinatus muscle. Again, this next slice is also this supraspinatus muscle, and I can even see the tendon here. The slice above it, I could see a shadow of the tendon. And as I page down through, and now I'm kind of out where I don't see that tendon no more. So once I see the muscle, then I can see this tendon, and I can bring my lines there, and I can go ahead and say, I'm going to take that angle right through where that supraspinatus tendon and muscle is located. But I don't know if I have the coverage now. So now I need to go ahead and page into the center of the joint. So about there. So here now, I can go ahead and make sure that I have the coverage that's needed, posterior all the way anterior in this coronal plane. Okay, so that's kind of how you utilize these axials. You look for the supraspinatus muscle, you page through, and then once you get that angle, you then go down to the middle part of your joint, and then you can see how much coverage posterior to anterior do you want to include. Now, not only am I going to angle off of my axial, I'm going to go over to my sagittal here and page through and see if I can get a good sagittal so I can see how do I set up for my coronals. And notice now I can get a nice coronal right through your humeral head and down into the shaft at this angle. Okay? So now I've got both of my angles set. I can go on, and if I want to turn my slices back on, I like how that is set up. Going back to my field of view here, again, this is warped only because of my double angle, but that looks pretty good here, how my field of view is going to show up. I have the option of choosing a phase of head to foot or a phase of right to left. Now, again, right to left is going to have any kind of my chest motion, your lung field going across this way. So if I would choose to go head to foot, then that takes all of this lung field motion head to foot, and I don't have to worry about that kind of bleeding over into my images. So I like a foot to head fold over direction. I do need to turn on fold over suppression because I have to worry about the lower part of the arm wrapping in, right? And notice how this has a rest slab that's built in. So if you feel like you want to go ahead and minimize any kind of flow motion coming up, you can position that here. Some techs will say, well, I want to change and put my rest slab over here again to minimize flow motion coming across from my artery and veins of the subclavian. And then I have still others will say, you know what, I'm going to do both. So I'm going to go ahead and put on another rest slab. And I'm going to take one of these rest slabs and I'm going to put it below my field of view here and take another rest slab and put it here to minimize flow coming across or flow coming up. And that's perfectly fine to do that as well. Okay? Now what you'll notice over here is you might want to just take this and move it kind of, you want to get it out of, well, you know what? I think if I move it this way, there we go. Just trying to get this out of the way so I can see all of this very nicely. And even though you're going to cut off a little bit of signal from here, I think that's still okay. Okay. So I put on 2 rest slabs. That's okay. My time is at 3 minutes and 52 seconds thus far. I'm going to go to a TR again. It says 4,000, a TE of 50. Well, we used that. Remember how it talked about using that 30 TE here? Even though, remember we even talked about PD, what is it, 30 to 45, it even talks about for good synovial fluid or good articular cartilage here. Over at the tip here, it talks about 30. My TR is user defined, but I'm going to change it to range, and I'm going to go back to this 2,000 at 8,000 and see what it does to my packages. I got it now done in one package. 3 minutes, 45 seconds with a TR of 7,776 milliseconds, and that would work as well. Let me see what TSE factor. It's got a 22 TSE factor, but remember for PD, we were kind of staying around what, that 10 range? 9, 10, okay? I think if I look in our book, for the PDs, they're using a 7 echo train length, okay? I think we were using a little bit higher last semester. Again, you can kind of play with that as you're scanning to see which, what you like best. We already talked about phase. Go ahead, Shalika, what's your question?
My question is since they both PDs, the last one we did too, should the parameters be the same or no?
They
don't have to be the same.
They don't have to be the same because of the fact your number of slices are going to be different of what your coverage, and you're using a different plane. So they do not have to be the exact same TR that you used. It'll still both give you a T1 weighting. Okay, so let me look at your book. Your book is telling you what you need to cover in your coronal plane, anterior to posterior. And I think I looked at this earlier, and I don't like how that anatomical coverage is listed. What it's telling you that is, first of all, your slice alignment should be parallel to your supraspinatus muscle. And that's kind of what we did up higher. There we go. We are parallel, right? And then it talks about being perpendicular to your glenoid. And here, if I draw a line here through my glenoid, that is perpendicular to it. Then it talks about coverage from your subscapularis muscle through the supraspinatus tendon. Well, technically what you need to cover, your subscapularis muscle is here, because here is your glenoid, here's part of the scapula, and here is your subscapularis muscle. Right behind it is my infraspinatus muscle, and as I page down here, then you'll kind of get into the teres minor muscle. Sometimes it's hard to differentiate between the teres minor and the infraspinatus, but we know that they kind of lie right up against each other. So the coverage for the shoulder should be to get this teres minor muscle all the way through. Here is your subscapularis muscle, but even to make sure you get through this entire joint. So even like up into here, go all the way through that joint. There are times that I see some abnormality or swelling here that I'll even extend it and do more. But if you see that you covered from the teres minor muscle, this is the deltoid, all the way through the joint, you are good. Okay, you've got the entire shoulder joint included. So I don't like how your book talks about the anatomical coverage, because it's confusing to say from the subscapularis muscle, which would be here, through the supraspinatus tendon. That doesn't necessarily make sense, because the supraspinatus tendon is located up higher. Okay, so I don't know if it's just a misprint in the book or not. Does that make sense to you guys, how to set these up for coronal obliques? Hopefully so. Because then I'm going to now go back and make sure that I get my shim box turned on. It's turned on auto, and I really want to do a volume box and turn it on myself. So I'm going to now adjust my field of view box or my shim box. Gotta get as much of the air out as I can. And position it like that. Now, if I go ahead and step back, I have my geometry the way I like. I like the number of slices that I have chosen. I like my contrast. My contrast is going to give me a good proton density weighted image. But it's at 5 minutes. Well, let me go to my motion tab, and I have 2 NSA, and I really don't want to bring it down to 1. But a way that I could make this a little faster is I could utilize my sense coil, and I can turn it on and maybe just use a P reduction factor of 1.3. That drops me just under 4 minutes. One thing I didn't look at is my voxel size, and I am well below 0.8. I have 0.5, which will give me even better resolution, right? So I like this. I like how my time is. If I scanned this and I realized that my pictures did not have much signal in them, what I could do is rescan this and take my voxel size up to like a 0.7. That'll give me a little bit more signal in my images, and yet I'm still 0.8 millimeters or less. By doing that, that even dropped my time even more, right? Because I'm making my voxels bigger. But again, this is where, as a technologist, you are going to need to decide and build your protocols. You know, what kind of a coil do you have? How many elements is in that coil? Maybe you have plenty of signal where you can keep your voxels at 0.5 and get even better resolution because I have plenty of signal to play with. Again, that is going to be dependent on the machine that you have, on the gradient strength that you have, and on the type of coils you have. Okay? So, but for all practical purposes, I like how this looks, right? But looks like at my volume box. I got to redo my volume box here. Okay. So I got about a 4-minute scan. I can go ahead and proceed and start. Now, if I was going to set up for a T1 coronal, I would set it up exactly like the proton density coronal. It's just that you're going to change the weighting, correct? You're going to change your TR and your TE and your echo train. For number 3, we're going to set up a T2 sagittal spare. Again, this is a fat sat. So I'm going to go ahead. I'm going to open this up. I can turn off my volume box, and it kind of like jumps up in here where you know, you only need to tweak it a little bit here, but don't be surprised if I change this to make you really think about how you want to change or set up for these sagittals. But if you want to right off the bat, go to my axial. Let's first talk about field of view. I'm sorry. So if I go over to my sagittal plane here, okay, my field of view is at 140 by 140, and that actually looks pretty good here, right? Notice how it's a little bit smaller than my coronals, but that's because it's on the sagittal plane. I only need to go anterior to posterior this far, whereon when I did coronals, I wanted to include a little bit more out here, okay? So my 140 by 140 looks pretty good in my field of view. Your book, if I refer to your book again, they like to do their sagittals 3 at default, and I have a 3 at default, okay? So if I start to set this up, then I'm going to go to my slice where I can see the supraspinatus tendon, and remember with my coronals, I angled like this because that's parallel, but for my sagittals, I want it to be perpendicular. So I'm going to go ahead and make it perpendicular to this tendon. Then I can go down to the center and make sure I have the coverage that is needed. Okay? And the coverage that is needed for your sagittals, and we'll go ahead and refer to the book here again, we want to make sure that we get the entire deltoid muscle through this glenoid fossa. So I can go ahead, I have my glenoid fossa, and I'm all the way through my deltoid there. And I could even page through these to see. And that looks pretty good. Okay? Now, I did a coronal already. So on this coronal localizer, I'm going to pull up a better coronal. This way, I can make sure I get a nice sagittal going right down through the humeral head and down into the shaft. Okay? I can kind of straighten up my... Now also notice that your book talks about your sagittals to be parallel with your glenoid. Well, if I take this line and I bring it back to my glenoid, I'm pretty parallel there, ain't I? So for sagittals, you're parallel to the glenoid, but perpendicular to the supraspinatus. So don't get those confused. I'll turn my slices back on. This is a nice setup. I like my field of view. I like my coverage. I have voxel size of 0.68 and 0.89. And you might say, okay, I'm going to bring this down to 0.6 and do a 0.6 by 0.6 here. Whew, jumped me up to 11 minutes, but let me go to the contrast page. I need to make this a T2 spare. So I'm going to go ahead and make my TR go back to my range, and I can go 2,000 to maybe 8,000. That brings me back to 2 packages at 4,145 milliseconds. My TE is at 85, and you can leave it at 85 if you feel like you want more T2 weighting, then you can add some more T2 weighting. If you feel like you like it more of 100. My TSE factor, well, remember we were always around in the 20s, so let's go to 22. Okay. This is a spare, so we're not going to forget about the volume box, but I'm at 7 minutes, and I have a 4 necks. Ooh, 4 necks for a T2. That's a lot of necks, so I'm going to bring that down to 3. Again, I can go to my sense and turn on sense and go to maybe like a 1.2, 1.3. Remember that the higher you go in P reduction, the faster your scan's going to be. But there's always that little sweet spot. You don't want to go too high because you want to collect as many true lines of K-space as you can, and then have the computer extrapolate the others. So, you know, if I go to 2 right off the bat, it's going to be like about a 50-50. Does that make sense to you guys? So I kind of try to start out with low P reduction factors and build it up as needed. And if I have a patient in there that there's no way they can hold still for 4 minutes, then I might use a 1.7, 1.8. But if it's a pretty good patient that can handle a 4-minute scan, I try to keep these P reduction factors a little low. Okay, so I actually kind of like this. Can turn on my volume box again. Make sure right before I hit submit that I did not forget about that. And I'm going to position that appropriately. Bring that down here. Oh, you're talking, that's right with these spares. Very good. I forgot about that because I work on a new Philips at OAO just recently, and it does it automatically for you on these new ones. But great question. As we go to these spares, we're going to go to our spare TR. This inversion delay is 90 and our spare TR is 306. So if I change that to 100, that's going to be about 1/3, and that'll give us the full fat sat suppression. Excellent. Thank you for reminding me of that with these spares. Remember, we want 1/3, the inversion delay, we want it to be 1/3 of your spare TR. What's kind of nice on the new systems is it'll do you automatically for you. You can turn it on auto and it'll automatically do 1/3, or you could still, if you wanted to manually change it, you could. Okay, so I like how this looks. It's 4 minutes, and I'm going to proceed and start. And if I know how to set up a T2 sagittal spare, I know how to set up a T1 sagittal. I'm just going to change my weighting, my contrast parameters. Now, according to the practicals, I do need you to go to viewing. So anytime you go to viewing, we're going to go to the eyeball. We're going to load our cases in. This is my Axial series. And I want to go to my proton density, or a T2 here. If I go, this is a T2 fat sat, because this will tell you up here what we're looking at. So we'll just go to any of these coronal series, and I want you to tell me where is the tendon coming off of the supraspinatus muscle. So if I page through here, okay, I know that my muscle is going to be here, and I could see already this tendon comes right off of this muscle. Here's your supraspinatus muscle. This is the tendon that comes right off of it, and it's right below where this is part of the acromion, but I can kind of see as I'm paging through, that's part of the clavicle here. Here's the actual joint here. Okay, so notice how close that tendon is, because sometimes this is where they're looking for that impingement syndrome, and sometimes your AC joint will get arthritic, or they'll have some spurring, and sometimes the spurs that grow off of these bones, think about this tendon being stretched every time you're moving your shoulder, and sometimes the spurring will actually cause the tendon to rip in there. Okay, and I think that's what I was just wanting you to identify as the rotator cuff tendon coming off of that supraspinatus muscle, which is your supraspinatus tendon, okay? Now we're going to go to a sagittal, which is here, and it's a T2 weighted fat sat. And as I page through here, it might be hard to identify what's anterior and what's posterior, okay? But once you see this hook, do you see how there's a hook off of the scapula here? If we go all the way in, we can see this nice Y view, okay? So as I page up and I start to see that there is a hook that comes off, that is your coracoid. And your coracoid will always come off anterior. So I know that this is anterior and this is posterior, okay? I can also see that this is your clavicle here. And I know that back here, this bone is part of the acromion bone. And it kind of makes the joint about right here, okay? So then I'm going to ask you to identify the 4 tendons that you can see off of these images. So I'm going to kind of page through here. And once I get to kind of the center here, well, right off the bat, I know this is anterior. So I know that this tendon that's coming off is the subscapularis tendon, because that is the muscle that is anterior to your scapula, right? So as I page through here, here's part of your scapula. And I know that this muscle that's anterior is the subscapularis muscle. And let me go back down here. So this muscle here is your subscapularis muscle. I can see a little bit of an indent here in the humeral head. You see there's an indent here. This is where your biceps tendon is at. I know right underneath the AC joint would be part of the, because you know these are sagittal, so you're only going to get kind of, bits and pieces of these tendons. This is going to be my your supraspinatus tendon. And then as I go down, and sometimes you just have to kind of page through these, I'm getting into my infraspinatus tendon. And then down lower would be that teres minor tendon. So I know it's hard for you guys to identify all of these, but what I'm wanting to look for is, first of all, you look at a sagittal and you say, this is anterior and this is posterior. Then, by knowing what is anterior and what's posterior, what I want you to be able to just tell me is, it goes from the teres minor to the infraspinatus, to the supraspinatus, and then all down to the subscapularis. So this, all the way through here, would be your rotator cuff. That is, remember, the collection of 4 tendons and muscles that make up the rotator cuff. So even though you feel like, well, which exactly is these dots? Which one is exactly? I'm not going to get all hung up on you being able to point out exactly where it's at. But what I do want you to know, or to be able to identify, is that which is anterior and which is posterior. And if I start posterior, we know that it goes from the teres minor to the infraspinatus to the supraspinatus, and then the anterior tendon is the subscapularis. If I asked you what tendon is in this little bicipital groove, well, then hopefully you can tell me, okay, that's where the biceps tendon is at. And in particularly the long head of the biceps tendon. Okay? So give me your thoughts. What do you guys think? You guys feel like, you can come in here in lab and kind of start to set these up pretty good?